And our next talk is from Shane Brady, who's at Arizona Public Health, and he is going to be presenting virtually. And I think we're ready to go. Okay.
Are you able to hear me?
Yes. Yeah, we hear you.
Okay, perfect. Thank you. I'm Shane. I'm the Deputy State Epidemiologist at the Arizona Department of Health Services, and I'm going to talk about the epidemiology of valley fever in Arizona. So coccidioides is endemic in Arizona. Healthcare providers and laboratories are required to report valley fever. However, we only capture a fraction of infections since most are asymptomatic or too mild to seek health care. And many of those who do seek health care aren't tested or diagnosed. And due to the large volume of case reports, cases are not typically interviewed, but we monitor incidence trends. Cases of valley fever have been reported to ADHS since the 1930s, and laboratory reporting was mandated in 1997. Since then, reports of valley fever have increased dramatically, with the majority of cases being reported by labs. There were also changes with one of our major commercial labs that reports more than half of our cases. In 2009, ADHS asked Lab A to begin reporting positive coccidioides EIA test results without confirmation by immunodiffusion, which greatly increased the number of reported cases. In 2012, Lab A changed their coccidioides EIA test kits, which contributed to a decline in the number of cases reported in late 2012 and 2013. And since then, we've seen case rates increasing, especially in the past 3 years. So in addition to the laboratory changes, other factors that could be influencing the yearly variability include migration of susceptible people to the highly endemic counties in Arizona, increased recognition and testing by healthcare providers, increased awareness and care seeking by individuals, as well as an increasing number of people with weakened immune systems, and then variation in precipitation and other climate-related factors, as well as increased construction or desert soil disturbance in areas where coccidioides is present. This is our public-facing valley fever dashboard, and it highlights some of the key points and questions with our surveillance data that we're going to dive into right now. So where is valley fever occurring in Arizona? Well, it's occurring in 94% of the cases actually reside in our 3 most populous counties, Maricopa, Pima, and Pinal. Those counties also have the highest rates and make up 82% of Arizona's population. We typically see cases and rates increase with age, and the highest number of cases in 2020 reported in the 65 to 74 year age group. And the highest rates were in those who are 75 to 84 years, which were nearly double the Arizona rates. Males accounted for half the reported cases in 2020. However, for the past decade, there's been a predominance of female cases, but prior to 2009, the majority of reported cases were male. So it's not clear why this shift has occurred, but we do believe that might be reporting, testing changes, and potentially care seeking. We use our hospital discharge data to look at trends in hospitalizations and charges. And in the past few years, we've seen an increase in the number of hospitalized individuals with primary diagnosis of valley fever. Interestingly, in contrast to our case data, we consistently see a predominance of males who are hospitalized, with the 5-year average being 57% male. In 2020, there were over $75 million in total hospitalization charges for Arizonans with a primary diagnosis of valley fever, and the average charge per hospitalization was over $50,000. We also monitor valley fever deaths through our death certificates data, looking at the underlying and contributing causes of death. We know that from analysis performed in Arizona that death certificates alone are likely to underestimate the true number of deaths attributable to valley fever by as much as twofold, but the trends should be fairly consistent in what we have. There was a large increase in deaths in 2020, and we suspect it's associated with the COVID-19 pandemic. The overall number of deaths in Arizona in general for 2020 was about 23% above expected amounts pre-COVID-19. We are continuing to investigate this increase and the potential impacts of COVID-19. So for seasonal variation in valley fever reports in Arizona, it's been consistently noted in past years that we have large increases in the fall and winter and sometimes smaller increases in the spring. These seasonal variations appear to be driven by changes in precipitation and other climate-related factors. However, these data don't necessarily correspond to the month of exposure or onset of symptoms. And some of the possible causes of delay between exposure and report to us include the 1 to 4 week incubation period, delays before seeking a healthcare provider, as well as delays in testing. And during our enhanced surveillance in 2007 and 2008, we found that the median time between symptom onset and diagnosis was 55 days. So in talking about enhanced surveillance, we don't routinely investigate our cases. However, we have performed enhanced surveillance in order to characterize valley fever in Arizona, as well as to validate our lab-only case definition. We contacted a sample of cases by phone and interviewed them with a standardized questionnaire in 2007-8 and 2012. And we got a pretty decent sample size for both of those. In 2007-8, it was about 9% of cases, and for 2012, it was 5% of cases. Some of the key findings that were individuals were symptomatic for a median of 4 months, 40% were hospitalized for a median of 6 days, 46% visited an emergency department, 26% saw a provider 10 times or more. 75% missed work for a median of 2 weeks, and 75% were unable to do activities of daily living for a median of 6 weeks. In 2012, 18% were hospitalized and 28% visited an ED, so those are down from the 2007-8. However, only 52% were diagnosed with valley fever, and 28% were diagnosed with pneumonia, 43% were prescribed antibiotics, and 39% were prescribed antifungals. We also looked at delays in diagnosis, and the median time between first healthcare visit and diagnosis was 23 days. However, we found that individuals were more likely to receive an earlier diagnosis if they were aware of the disease, and they were more likely to ask for testing if they knew about valley fever prior to their illness. In addition, we also wanted to understand testing in emergency departments, as a large number visits emergency departments during their illness. So we examined emergency department visits from 2014 and looked up CPT codes for valley fever testing. We had 2,672 ED visits that met that criteria. The majority of them were in Pima County, which is our second most populous county, more 45 years of age, preponderance of females, and 99% were discharged home. And one of the main findings was that 10% of providers and 9% of healthcare facilities accounted for half of all patients tested for valley fever and EDs. So we have this really small number of facilities and providers accounting for that disproportionate number of tested patients. We've also assessed clinician awareness through 2 CAP surveys of physicians and nurse practitioners, including adherence to IDSA recommended guidance. 84% in 2014 reported confidence in ability to treat, which was up from 50% in 2007. 60% reported working knowledge of different laboratory tests. And those who had received a valley fever specific CME in the past 3 years were more likely to counsel patients about valley fever, test patients with community-acquired pneumonia, offer treatments to immunosuppressed patients, and test asymptomatic patients with underlying conditions. We also assessed public awareness by adding questions to BRFSS, which is an annual population-based telephone survey about health behavior. So we asked if individuals have ever heard of valley fever, if they knew symptoms, and if they knew someone who had the disease. 3% had never heard of valley fever compared to 20% in 2008. So we did see increased awareness, which was good. However, 39% only were able to identify one symptom. And only 5% correctly identified fever, cough, and fatigue as symptoms, which are the primary symptoms that we promote for recognition in our educational materials. And 30% of respondents knew someone who had valley fever. You can see some of the challenges in terms of education and recognition, and we really see that recognition is critical to earlier identification and better clinical management. So a big focus of our program is really on education, and we partner with the Valley Fever Center for Excellence to develop and disseminate both public and provider education. We've developed English and Spanish brochures and disseminate them through our library systems as well as through our MVD offices to inform hopefully new residents who may not be aware of valley fever. And in the past 5 years, we've distributed over 7,000 brochures and pamphlets. We've had challenges with the library systems with COVID, but we're hoping to increase some of that awareness in those settings. And each year since 2003, the governor's office in Arizona issues a proclamation for Valley Fever Awareness Week in November. We're currently in Valley Fever Awareness Week for this year. It's November 12th through the 20th. And really the intent is to promote awareness and enhance recognition among the public and providers. We update our dashboard and report. We post directors' blogs, push out social media, have PSAs in Harkins movie theaters across the state. And we also run a youth poster contest, which I'll talk about. And we've been running this poster contest with the VFCE and Arizona schools since 2018. These are all the winners from the previous years. The current contest hasn't ended yet. But we've gotten a lot of great engagements from classrooms and Arizona youth and have received nearly 600 submissions since we started. The key takeaways are that valley fever cases in Arizona have been increasing considerably in the past few years. The impact on individuals with valley fever is significant, with many experiencing delays in diagnosis and months of symptoms. And public and provider education can lead to earlier identification and better clinical management. I want to thank our team as well as CDC, Valley Fever Center for Excellence, TGen North County Health Department, reporting labs, and providers. And thank you. And our website is valleyfeverarizona.org for those who have questions. coxie@azdhs.gov, the best email to reach us. Thank you.
Thank you so much, Shane. And of course, we'll hold questions. So that was what we're doing for surveillance, what we understand about the distribution of the organism amongst patients and different patient populations.